I am the Vice President of the Clinical Services, and I work directly with our medical directors. We have two of them, one that specializes in the radio frequency and one that specializes in Tehrmi Va. The Tehrmi Va one is our Urogyne specialist, Red Alansad. I don't know if anyone knows him, but that's who I work with. So as I get through this presentation, most of the information, it's directly coming from Red. As a distribution company, we can't give out a lot of this clinical information. So what I'm sharing is what he's learned over his 3 years of helping us develop this product and the end result. So if you have questions, I will give you in reference to most of what he's taught me or what our other key opinion leaders have found over the last 2 years of using this. Okay. My background is I'm an advanced practice nurse. I'm not an MD, but I am surgically trained. So I have been doing liposuction and fat transfer with some of the world's best for the last 15 years. So that's where I came from, and then Tehrmi snatched me up because I had a lot of surgical experience and it fit well with this product. So we're going to talk about the non-invasive, but just to give you an orientation of the rest of the products and things that we do, we're a pretty large platform. Their technology starts off with Tehrmi Tight, which is our invasive. We're going to be doing that next after this lecture. We have another one, we'll discuss that. Tehrmi Race is our neuromodulation, where we knock out the glabella or the platysmal bands. It's very interesting. Tehrmi Dry is for hyperhidrosis. So this side is all of our invasive side. What we'll be talking about is the non-invasive side. Tehrmi Va here is what you're all here to hear about. This also has a modality called Tehrmi Smooth, which is a non-invasive that actually your staff, anyone other than yourselves, would be able to use. It's a nice way to just bring in some added revenue if you're looking for another way to complement your technology. So we'll talk about Tehrmi Va. And remember, I'm not an OBGYN like you all, so I may not have all of the answers. I'll find them for you if I don't, but I'm on the clinical side, so I can tell you more about the procedure itself, all of the results we see, any other questions you have about the actual technology. Okay? So I know a lot of the questions that people come up with too is going to be how you present this and how are you going to sell this to your patient population. So we'll talk about that at the end too if I haven't addressed it as we go through. Okay? We have found that these women are seeking a number of different things. It's first started off with the laxity, both internal and external, and as we evolved and worked with the technology, we found these added side effects, if you will, anecdotal side effects, because we're not FDA approved for those, but we found that we were getting significant improvement in other areas, and it turns out those were even the higher demand of the patients than the laxity itself. So that's really what's driven us in the States. 50% of the time it's unreported. So what we have to help you figure out is how are you going to get your current patient database, I don't know how large your databases are, hopefully a few thousand at least, how we get them to convert and realize that there is even a solution for some of the problems that they have. They don't even realize that it is something that can be repaired or fixed or improved. $7 billion market over the next 4 years globally, which means a lot of money in your pocket if we do this right. And a constant revenue stream for OBGYN practices. You have the best patient population for this. You have every single person that walks in your door has one of these complaints more than likely. So we're working on these concerns: loose vagina, both external and internal. Atrophy, whether it is menopause or post-cancer patients. We've had a lot of practices that have cross-referenced with their oncologists to work with their patients who have significant dryness to the point they can't have intercourse. They've been years without it. And those patients can't be on hormones or do anything for it. So this has been a lifesaver. You wouldn't believe the testimonies we have on just the atrophy patients alone. Leaky bladder. This one we're going to talk more in depth, and it's, like I said, it's not my specialty, so all of the advanced complications that patients may come in saying that they have SUI, but it's really other issues. You are in a better place to be able to diagnose this, or your urogynes need to be able to get involved and help out with that. But this one, and I speak to that personally, is brilliant and works great. So we just finished a treatment for the same reason, and likely she will see those results tomorrow. It's usually immediate. Fallen bladder, and this is going to be mild to moderate, but nothing severe. Okay? And then orgasmic dysfunctions or disorders. So that's everything that we've realized we can improve. This is what we charge in the States to have the protocol, which the protocol is 3 treatments. Okay? The treatments are 1 month apart for 3 treatments, and they take about 30 minutes on average. And this is pretty standard, is about the 3. In lower socioeconomic areas, we might see more like 2,000. This might be high. In areas like LA and New York and that, they're definitely getting the 3,000, 4,000.
For the entire?
For the package, yes. And to really discourage you, can you guys turn that down? I'm like sweating in here all of a sudden. It went from 20 to 25. It was a bit of a jump. Yes, what was, sorry, I lost my train of thought. It should always be sold as a package of 3. It should never be sold as a single. The protocol was designed to work as 3 treatments. So when patients come to me after 1 or 2 and say that, well, it's not working, well, you haven't finished all 3. So you really want to sell it as a package.
How frequently do they have to have a top-up after the 3?
We're going to discuss every one of, and it's because that's fine. It's no, because sometimes you'll prompt me for things that I'm forgetting, so that's fine. We have a whole hour, and I talk fast. So if you need me to slow down, please tell me to slow down. Each one of these, I'll tell you, because some of them are slightly different for when you start seeing results and how long they last. So we'll review each. So the technology is a radio frequency. It's monopolar. So everything must be grounded for it to operate. Obviously, it leaves the tip and doesn't go anywhere until it reaches the grounding pad. Where our operating range for this procedure is 35 to 47. Typically, for this procedure, you're going to treat the internal vaginal vault. I can test you because you just did it, at 47, okay? And the patients tolerate that just fine. And then the external treatment will be done at 45, okay? I'll show you, you'll see a video of it in a second of what it looks like. The results are consistent with the connective tissue changes leading to the fibroblast stimulation. We're also creating some neurogenesis along with that and replacing the collagen. So we're protein denaturing, collagen remodeling is what we're doing, right? And at temperatures between 42 and 44, we know that that happens on tissue. This is just talking about the differences, and you guys are going to have questions for me about the differences in different technologies and competition and CO2. And that's what this is talking about here, is that we're not creating a necrosis. We're promoting increased blood flow and blood circulation so that everything else is waking up. So it's really significantly different than you blasting it with a CO2 laser. Besides the fact we can treat so many other conditions that the CO2 isn't about to treat. And I think that might... well, because I think the next one might be my video. So yeah. Is it starting? Oh, it is. Okay, so this is the electrode, and I'll pass it around. And this is just the animation, which is a really nice one to use for patients. It's not graphic. We have other graphic ones. But this one, anyone can watch and not be offended. And it just kind of shows them what it's doing. And then he's going to show the internal. So I think it's a really good tool for your marketing purposes without it being too much. I mean, if you're in your practices, you can show this on a loop in rooms and patients wouldn't be offended. And it's just showing them exactly what it's doing. There'll be a new one coming out because we are coming out with a new design. It's actually already out, and we'll talk about that. So as you see here, this is a handpiece here with the electrode. The next generation is out. I don't have it here because this was shipped before. We just started this last week. So they are out, and it's an all-in-one piece. It's a much better design. It took away any of the errors and complications, the problems I had with it faulting. So now with the all-in-one, it's no different in that it's a single use. It's always been a single use. Currently, if I disengage this electrode even 2 millimeters, it has a red lock, that pin that shoots up, and it locks it out. It can never be re-engaged. So your patients appreciate that and like that. So I typically, when I start my case, I have this on the bed so I don't forget to ground my patient, because all of a sudden you're working and you're like, why isn't it heating? Why isn't it doing anything? You didn't ground. And I have this all here so they know this was brand new. I just loaded it. It's theirs. And I disconnect it and throw it in the trash when they're still on the table. So it's a single use. The new one is just a solid design. And in case you think you can cheat the system, you can't. It is designed so that if you try to autoclave it, it completely melts. And if you try to submerge it or clean it, It actually has cottonoid, like a tampon in here, and it absorbs all the water, and then things leak and it contaminates. So it can't be reused. Specifically designed that way. We'll talk about the centimeters and how we do the treatment in a few minutes. But I will turn this on too so you can kind of see what this looks like. Oh, we could plug it in. Do you want to help me with that, Dr. Friedman? I see it in the back. There are many patients that cannot tolerate that size diameter, and especially not your atrophy patients. And I have taken some of the worst atrophy patients, and they're hugging you at the end. It takes a little bit of work with them. Sometimes we do 2 weeks of massage with oils just to get them to open up a little bit so that the electrode can go in. But you would be surprised at the improvement after the second treatment. Backside, turn it on in the back. So we already talked about the left side, the things that we're treating. But to make a good point here, there is no pain. They should feel absolutely nothing with these temperatures or this technology. So they tolerate it just fine. No downtime at all. And our competition certainly has downtime. So our patients can actually go home the same day and have intercourse. And most of them will say that their significant other can tell a difference. If they're there for tightening, they can tell a difference. And for any age. So we're not doing any tissue damage. There is no downtime. There is no risk of infection. There is none of that. We're not breaking skin. In the States, I don't know what your laws are here. In the States, this is not done by the physicians themselves. It's done by all of their assistants. It's a Class 2 device. So for us, it doesn't have to be done by the MD. I go back and forth on that. I think it should be done by the MD, but with an educated person that you trust and is well trained and has the experience, it could be in the right hands. But all patients should be screened by you and their H&P reviewed and all of their contraindications reviewed. Somebody remind me to talk about contraindications in case I forget. Okay. This is just talking about how the radio frequency works. I'm sure all of you have used or know of radio frequency. Obviously, this electrode is a little different than our other device in that it's much thinner. So it's extremely accurate as far as the temperatures. So here when you start up, we're going to be using the Tehrmi Smooth because it's our other transdermal treatment. So it's the same settings. So here, when you see the set temp, I'm going to set it at 47 because that's the maximum and that's where I usually start internally. So it doesn't go above 47, so you have a safety mechanism. It can't go over. It can't go over 47 because the technology works like cruise control on your car. So if I ask for 47, it's not going to 55. It can't. And when it gets to 47, it's not continually delivering. It's pausing. So it's waiting for you to be a little bit below that and a little bit above that so it can just give you the constant energy. Okay? And then the actual temp is what this is reading. And because of the thickness, or not thickness, of this, it's very accurate within a degree or two. So we're treating at the temperatures we're asking for. So yes, I mean, we all know this. You get skin tightening, mucosal shrinking at 42 to 47. Same principle here. Heating up. We typically will reach that 47 point in about 30 to 45 seconds. And then we're going to continue the protocol. And I can review the protocol so you understand what you're doing. External and internal treatments. I don't think that's a video. So the internal, typically I tend to start there, mainly because the patients are a little anxious about it and unsure, and you can see their anxiety. But the internal has no heat sensors. They don't feel temperature. So when they realize that there is no shocking, it's not going to hurt, all of a sudden their anxiety is gone. The outside obviously has more, and so I just prefer to start internally so that I relax them and they're not anxious about it hurting. And the rest of the procedure usually goes a little more smoothly. So the first thing you do is when you enter it is to go all the way back to the back wall to the cervix. And once you realize how deep their vault is, you'll back out 1 centimeter. So if they're 8, you're going to go to 7. If they're 10, you're going to go to 9. And some of them are 11. You go to 10. So it just depends on the length. You want to make sure that you're not bumping up against the cervix. It's probably one of the calls I get the most is my patient spotting. Well, that's because you were too aggressive and you were hitting the cervix. So avoiding that. And then this is just treating on the external. The only thing is that you always have to remember that the electrode itself has to be in full contact with tissue. It's not doing anything unless it is. And if you're floating and not in contact and you come off, gets extra hot right there. So they're going to yell at you. So the key is just how you apply it with pressure and how you move so that you stay in contact. As long as you do that, you're getting results. This is something you guys all know about protein denaturing, collagen remodeling, elasticity, and how that works, and at what temperatures. The 42 to 47 is ideal. So it's really just review. It treats the clitoral nerve bundles. We're increasing blood circulation and waking everything up. So when we do the treatment, I like to break it up based on what the patient's complaints are. And I'm going to say that Red Alensod said that. Because if my patient is complaining of stress urinary incontinence, you're going to want to focus on the internal sealing and probably around the nerve bundles around the clitoral hood that also feed from the urethra. So you want to focus on an area and spend more time possibly there. Our protocol calls for each area to be treated 3 to 5 minutes. Okay? So the areas are, in the vaginal vault, you have 4. You're going to have the floor, the ceiling, and the 2 walls. On the external, you're going to have your right labium majora minora and your left. And on each of those, I include the clitoral hood or the introitus, divided up. So your total treatment is 30 minutes long. Some people go as long as 40. And I do have some of our KOLs, our key opinion leaders, who say, you know what, on the external, when I spend an extra 5 minutes on each side, they get tighter and they look better. So that's all on your call. Our protocol is just a suggestion. What you do with it, you can take it to any level. This is talking about the thorough neurogenesis, which Dr. Alensod is big on talking about the vaginal lubrication. I mean, we really do have patients that after their second treatment, at about 2 weeks after, that's when they notice a significant change in their lubrication. Some the first treatment, I mean, every patient's different, but on the majority, it's for the lubrication, it's after second treatment, week 2. What is that? Another video?
Yes.
Is it coming up? Okay, this is going to be his treatment, so I'm going to let you guys watch this just so you see it being done. He's just doing his assessment first. I have seen so many wow patients after one treatment with external laxity. Some of that is swelling, I agree, but not all of it. I mean, you can see a significant change after one. And others, it takes all 3. So notice, now he's doing a technique this direction. We typically teach this way as long as you have a pelvic bed, as long as your elbow's down and you can get the full length. He's treating in the folds. He's treating both sides of the labium minora and majora. He's getting in those crucial folds. He's treating around the clitoral hood.
Which type of gel?
Oh, this is all done with ultrasonic gel, just clear ultrasonic gel. This is about the pace too. That's not sped up. That's about right as far as the pace. I like to, I'll explain how you break it down in a second. Since he did this, we've increased our temperature some. I don't know if you just noticed that. It said 40 to 45. We've gone up.
What happens to patients delay their treatment instead of having it monthly, they come in after 2 months or 3 months? How does that affect? Do you have to start again?
Yes, for certain things. It's really going to set you back. I can tell you from the urinary stress incontinence one, you can't do that. It is stacking on each other to get that maximum effect so that it lasts a certain length of time. So it needs to, it should. And they really do need to show up on time for their treatments. I mean, if they miss it by 1 week, it won't be that much of a difference, but they miss a whole month, that will make a difference. I was guilty of it. I travel internationally every week, and so I get lazy. I just didn't go for my second. Well, then I was back to square one because I didn't stack on it. So It really does make a difference. You do need to keep them in line. So he's just reviewed all of these: tightening, smoothing, softening, moisture, sensitivity, fullness. Introitus tightening. Questions? No? Okay. Of the laser. No downtime? I don't know if I believe the no downtime, but okay. Introidal tightening, full depth. And this is just talking about the things, I think I've mentioned most of them. Some of the things that are interesting that we don't really push or talk about is that, and I don't have the science behind it, I can't tell you why, I can just tell you we've got so many patients that have voiced this, Red has, is that for some reason the patients that have repeated bacterial vaginitis, it is stabilizing their pH and they're not getting the repeated infections that they're usually getting. It definitely has worked for that for some patients. He puts it here, yeah. Tightening of all the muscles. We know radiofrequency will do that. If you're putting heat on a muscle, it's gonna tighten it. So that's why we also talk about spending more time on the pelvic ceiling to get that pelvic wall to tighten up. So if you have 30 minutes and that's their concern, most people will spend 12 to 15 up there. Let's see. These, stage 1, even sometimes stage 2 is okay. He's treated quite a few stage 2. I will share with you, there's a frequently asked questions that I put together. It's about 45 questions that you all come up with that, you're like, can I treat this? Or how does this get treated? Or why is this working? And he's answered all of those for you. So if there's things that I can't answer, it's likely in the FAQ as well. And we add to that all the time. So we update it as more people email me. I have just a clinical email where people send all their questions, and we update those FAQs so that you know who's asking what and what else is going on with the technology. Increased sensitivity. So this is on your orgasmic dysfunction. Sensitivity, nerve sensitivity is improved. The theoretic G-spot, for those who, if I say G-spot, they're like, well, there may not be. So theoretic G-spot. Shorter times to orgasms, more intense orgasms, and multiple orgasms. One of the things I want to comment on that reminds me is that people will always ask, well, I don't want more orgasms, or I don't want to be any tighter. If you don't have a problem, we're not improving it. So we're not making you tighter if you weren't loose to begin with. There isn't something to improve on. So that's one of the key things is people will ask you is, I don't have a problem with that. I don't want it any more sensitive. It's not going to change that. This is improved circulation. He's just showing your pinkness here and the increased moisture. You can see the exudate right in here. These are two good examples of the same. Before, after, before and after. And these are 3 months, so this is all 3 treatments before he sees this effect. And these are some of his immediate. This one's over 3 months. And this is pretty typical. This is what we see. This procedure has been so successful for us, we can't keep it in stock. I mean, my team is out installing this. I have 10 nurses that work for me in the States, and they are out doing these every day of the week. We have practices that have paid for their technology after 1 month. They have enough cases that they've paid for it. We do set up a lot of marketing things where we will do events, and we'll send one of our reps in. We do a huge event, and before the end of the event, I've had people that have sold 40 packages. It's paid for. So they do a huge event and pre-sell this ahead of time. Is a huge benefit. See, this is immediate, and this is after 1 month. That's impressive, and that's pretty normal. You'll see this. No anesthesia for this either. So there is no anesthesia. They don't need to take anything. They'll feel nothing. So some of the differences in the lasers. Dr. Allenside has a whole presentation where he lists out all of the differences with the laser. I do have that if somebody wanted to see those slides. I'll share them with you. I can't transfer them into here, so that's why they're not up there. But it's long lists of every difference that he sees with the lasers, including the large barrel, Now they've started coming out with handpieces that will treat external, but some of them still don't. I don't know what you have cleared here and what you guys use, but some of them still do not have anything to treat the external. Higher capital costs and or disposable costs, and higher maintenance costs. This is there's nothing that breaks down. It's a single-use item. The whole thing goes in the trash. There's no moving parts that you need to worry about. There's no bulbs you have to replace or minutes that you need. There's none of that as far as extra expenses. I think we've covered that. Maintenance. Let's talk about the maintenance program. So when they come back, it's different for the different complaints. For just all of them except external laxity. Okay, so everything but external laxity, after they finish their 3 treatments, can typically see they won't come back until 9 to 12 months. So they're coming back at about 9 to 12, at about a year to have another cycle. And there'll be another round of 3. Some patients have not done 3. They'll try 1 or 2 because they've got an improvement. Things are really improving, and that's fine. And they can save the 3rd until they need it. So you just kind of use it as a maintenance program, and they buy the package and use it as they need it. The external laxity, pretty much everyone says, we usually use the phrase, it lasts as long as Botox. So, your Botox works for 3 or 4 months. I say 4 months, yeah. So there for external laxity, they're coming in every 4 months. So you can also price this different ways. It doesn't have to be $3,000 for the whole kit and caboodle. They might only want external or only want internal, and you price it based on the number of minutes you're in there. That you need to, if it's a 15-minute procedure versus a 30-minute procedure. What? The cost of the handpiece is not going to change, correct. It is not going to change. It is still the same disposable cost. And I don't think I've ever treated just one or the other. Every patient, I treat everything. So it's just overall makes the appearance, the tightening, everything better. So that's the internal. We talked about that. External vulvar treatments. I don't know that I have 2 years on that. We're typically seeing our patients coming back at about 1 year. So, and as far as, let's talk about contraindications while I'm thinking of it. So our contraindications for radio frequency, the technology itself, the generator, doesn't say that there are contraindications. That's radio frequency in general. The manual doesn't say it. We have suggestions based on our experience. So we suggest nobody with any sort of cardiac device, AICDs, defibrillators, that type of thing. Anything that's programmable. So even like a neurostim shouldn't be used. Obviously pregnancy. And then the one thing, cochlear implants are okay with this. With the vaginal, they're not okay if we're doing Tehrmi or other Tehrmi procedures on the head and neck. We can't use those. Some people question autoimmune diseases, so I believe we are adding autoimmune diseases to our consent, and I don't know why he chose that, but we are adding it. That's what Red Allen said wanted to add. So the consent has everything listed in it as far as the contraindications, and obviously it does say, no prolapse more than this and things like that.
What about after vaginal surgery?
Oh, no, it's fine. It's going to, no, it's...
After a DVT or something like that?
After a DVT?
TVT.
Oh, no, it's 2 weeks after. No, it's going to increase blood flow. I mean, he loves to do it with his surgeries because it actually helps and promotes his healing. After delivery, 2 weeks after delivery, he'll be using it. So he thinks it helps heal everything. And can treat breastfeeding patients. He says 6 weeks, but I know he does it earlier, but the protocol says 6 weeks. And vaginal repair. So there's your question right there. It's all in the FAQs too. These are just a couple of them. There's, like I said, over 40 on the list. Negative pap smear within 2 years. We do ask that you request that for obvious reasons. So we do ask for a negative pap. And then the lichen sclerosis has improved incredibly. Patients have had great improvement with that. And that was one we weren't sure, and we just kind of did a little mini study on that to see who was getting improvement, and it's worked great. So another...
Appearance and symptoms like itching or that?
Yes, all of their symptoms. Yes, all of their symptoms. Yeah, they were significantly improved, and yeah. Red hadn't treated a whole lot of them. It was some of my other doctors around the country that started asking. And so we said, there's no reason you shouldn't treat them. If anything, it's going to improve. And then the feedback was that they were significantly improved.
Any idea for how long it lasts?
I'm sorry?
Any idea for how long it lasts with the...
I don't know. It's something that, it's certainly, we're at 6 months. Because I had 2 or 3 doctors at the same time asking me the same question. Okay. And that was about 6 months ago. So I haven't had a follow-up that they've had another treatment yet. And they're supposed to call me when they do. So I don't have extended because it's something newer that we were seeing if it improved.
Did anybody try to treat lichen for girls, for young girls?
No, no. No. The only other experimental, like moving outside of what our normal scope is been for anal treatments. And we just started doing that about 3 months ago for anal tightening and anal leakage for homosexual groups. So, and others too, just for other issues. They've also tried using it on for hemorrhoids to shrink tissue, and they see improvement on that as well. If anything it's touching, it's going to shrink, so it's going to improve any of that. But it's worked great anally. They started with the temperatures a little lower, though, and go by tolerance. So you start your temperatures more 41, 42, and go up slowly. But
any information about bladder pain syndromes, IC, and so?
What syndromes?
Bladder pain.
Bladder pain?
Yeah.
I don't know if that's in the FAQs.
No.
I don't know the answer to that. I can look on the FAQs, or I can text Red, because I've already texted him twice today and he answers me like that. So if you have a question I don't answer it, I can send him a quick text and we can find out the answer.
All right.
Okay. So just grab me at the end and we'll send him one. Let's see. No anesthesia. We already talked about all of this, how long the procedure takes, when it's repeated. You guys know the answers to that. What they feel post-procedure? Nothing. They really don't. They can go right back to all of their regular daily activities. Some people may complain of a little bit of crampy, achy feeling. That's pretty normal. And then the only other symptom you could sometimes see is spotting if you hit the cervix too many times. That you bump into that a few times, they might spot. If you have anything else that occurs, we usually tell them they need to go see somebody then. It's not related to us. The only other thing I teeter with, and you guys would know better than me, is whether or not to treat external first, because I don't want to contaminate internal over the urethra and cause a bacterial infection if I could be. I'm not really sure. So I haven't had complaints of it, but it could exist. So that's, at least some doctors have said they prefer to treat external first for that reason. So just to throw that out there, it's certainly, and we treat the little hood, but we don't treat over the urethra. So
You can wipe it.
yeah, you can. Yes, absolutely. And we actually, the product that we use, and you guys they'll probably find something for you, but we as in I, had to research to find something, because when they came out with this, nobody thought about how to clean it. And I'm like, we need something that's a broad spectrum that kills everything. And so this one is, and it's easy to wipe the handle and wipe everything down. So it's a broad spectrum cleaner that I recommend. But we can certainly figure out, if you can't get this, what works here.
The question is, if in the middle of treatment, so it's heating already, you did internally, want to go externally, and from aesthetic reasons you want to wipe it clean before, would it make any difference because of the temperature?
No, you're going to pause it. Yeah, the technology has you have 2 ways of on and off this technology. That foot pedal, can you reach that? So you have it's just an air compressed foot pedal. You tap it on, it's on. You tap it off, it's off. That's all it is. There's also an on-off here. So if you finish your internal, I would tap it off, take my Protex, wipe it off, apply my gel, because you need lots of gel for the external. The internal, you typically don't need any. They're moist enough, unless they're an atrophy patient, and then you certainly need lots of it. But I would just tap it off, wipe it, and then put on your gel and wipe. You have to heat your gel up anyway. So we do recommend that you put your gel, and I haven't told whoever works here.
Is it a regular ultrasound?
Yeah, it's right here. Yep, just regular ultrasonic gel. But I like to put it in a baby bottle warmer, because it works much better if it's already warm. Otherwise, the technology is racing to heat up the gel before it can get to the tissue. So it's much faster if you just use this. It'll get you. It feels more better for the patient, more comfortable for the patient. They're not, because when the technology is racing from cold to get to the temperature it asks, so it's racing from like 21 to get to 47, it's like your car going up a hill. It slams on the gas. well, that can be uncomfortable to the patient. So if your gel is warm and you place it down and it's already at 44, it's brilliant. Then it's up to temperature right away, and now you're effectively treating the tissue versus spending your time heating the gel. Spotting and bleeding, I just talked about that. There it is. It has no effect on the menses. Sometimes I'll get a call and like, oh, I started my period. I'm like, it has nothing to do with us. We're not changing that. It just doesn't make sense. So if that's also in the FAQs, it shouldn't do anything to change their cycle, their flow, anything at all. Post instructions. If they have spotting, we tell them to stay out of showers and baths and hot tubs until the spotting is stopped. But that would be the only thing. Other than that, there is no downtime at all for any of it. So that's the presentation. Trying to think of what about the protocol I didn't cover. I think I covered most of it. What other questions does everybody have? Because you must have some.
Untreated bacterial infections, and we're not going to know the time of treatment.
Actually, the first thing that comes to mind, and I've sadly, in where was I? Peru. I stopped the case. I'm like, it was the only patient we had for Tehrmi, but I stopped it because she had the worst raging yeast infection, and it was obvious. That's mainly the one that you're going to see and know that they've got an infection. And
Some patients do have chronic.
yes, they do, and they need to be. If they don't know it and you notice it, I stop the case and have them treated first, and then have them come back. Mm-hmm.
But it's not considered contraindication.
It's not. We've gone back and forth on whether or not the heat can kill it and make it better, or whether the heat promotes it and makes it worse. So, and I don't have a definitive answer for that. I have doctors that go both directions, so it's really going to be your own personal call on that one. And even when if they're on their period, treating them isn't a contraindication. That they can have the treatment. We usually say just for their own comfort that we don't do it when they have a heavy flow, but otherwise it really doesn't change anything as far as our treatment. But I've stopped the yeast infections. I stop. I'd rather be safe and wait and treat them first.
Did you also do histologic preparations to see the promotion of collagen? Because I find it really mind-blowing that it's immediate. The effect is immediate. That's why.
I don't think it's well. No, it can't. I mean, protein denaturing and collagen remodeling isn't immediate, so that takes time. You can see some change, but we know it breaks down and it takes time for that regrowth. So that's kind of why those treatments are a month apart. It's to allow for that effect to start working, so that then you stack on it. But it's also why at the end of 3 months, what you did in the first month is now really taking effect, and that's why it's lasting you up to a year. So
I just wonder what happens in the first, like.
There's immediate contraction, like the CO2 laser. Heat just causes immediate contraction. And then there's a second result of the collagen formation. Immediately there's just the heating of the tissue.
we have, we know from the heating, we did some studies, we took abdominoplasty tissue, at least for our other radiofrequency, and watched the shrinkage to see, does the second pass make a difference? Where the shrinkage was coming from. And the first pass was a 24% reduction. The second was a 0.2. It didn't make any sense to do a second. It was like so minimal, the second pass. So we know that radiofrequency on tissue does tighten tissue. I mean, that's immediate that you could see it. It was measured immediately with, the dot studies and measurements. What other questions? We've got to go over patient selection. What about patients' demographics or pulling, finding your patients and?
Who typically are patients one would reject?
I'm sorry?
Who typically are patients one would reject?
One would object? Reject? I'm not, well, we talked about this earlier that 80% of the time when they come in, even if you're not an OBGYN, those patients that come in don't have any issues. They're not putting anything down as a complication. I have had some practitioners call and say, okay, I'm in there and this is a big prolapse, or this is, you got to stop the case, send them to go get examined and get cleared. So what clearances you want or need are going to depend on what the problem is as far as sending them to Urogyn's or what your specialty is. I certainly would reject anyone that has prolapse greater than a 2 for sure. You're not going to do anything for that. My biggest concern is, and it's not a concern because you typically aren't going to hurt them, you're just not helping them, and then they're frustrated and they've spent a lot of money, is the ones who have other issues that aren't truly urinary stress incontinence. They're actually other medical conditions, and they don't realize that it's not just, they think it's something simple and it's not.
There was something about OAB as well.
Yep, overactive bladder. It works for mild to moderate overactive bladder. But both of those diagnoses have could be other things that are more significant. And that's not my specialty, but I have a list of them. And Dr. Alansad has a really extensive H&P that he does. He's Urogyn. That's what he does. But I feel like everybody should kind of review that and know, wow, there are a lot of other things that we need to exclude. So I think it's really just making sure that that's the most significant one of the calls I get where patients aren't happy because they didn't get a result. Well, it's because they had something more significant going on and this was not the procedure for them. And they weren't properly screened for that. Other than that, the average patient that's coming in for these other complaints, I mean, the me's who know that it's just when I run or sneeze, that's easy. It's nothing else is wrong. The tightening is very easy and obvious. So I think I don't know if I'm answering your question, but it seems, and I have patients that lie, and you get in there and like the yeast infections and the different things, and you're like, okay. Or any sort of active herpes lesion, we don't treat, we stop. So there's a reason to definitely be the physician or someone is very good at a manual exam and at least looking and knowing before you start a procedure.
Going back to herpes, that's something I wanted to ask. Patients with recurrent herpes, pre-treat with acyclovir?
Yeah, I would. Yep. If you know they have it, if they're frequent, absolutely. Well, that's the same. It's no different than when we treat anywhere around the mouth. You do any heat around the mouth, CO2 or anything, we always pre-treat. So it's the same thing. The heat could bring it on.
Does these patients have to sign informed consent?
Oh, absolutely. Mm-hmm. We have all the forms. We have treatment records, consents. Mm-hmm. Yep, we have all of it. It's a complete package of everything you need to get the case done.
So is FDA for tightening and incontinence?
No, no, just heat on tissue for tightening. That's it.
Okay.
Yeah, no, not incontinence.
Tightening, but also in the vagina.
Yeah. Well, the technology is FDA approved.
All right.
It's being used on the vagina, but it's not for the vagina. Correct. Yeah. But
Vagina,
elect-
not that indication
That-
has not been studied so that they could market. But what doctors are doing in their offices, something else in the States, in order to get an indication, they have to do clinical trials, get an approval to be able to market it.
Yeah.
But it is approved to use
Yes.
in that neighborhood. But they cannot say it works for this indication.
Right. So this is approved. So this handpiece is approved. Right. We have 4 IRB studies to try and get every one of those other clinical indications. We're actively working to get those. So we have all of them underway. They've been underway for quite some time. But you know how long it takes for us to get that. So it could be another year.
What's the patient treatment base in the US?
I can get that for you. In fact, I might even have it because I asked somebody that a while, how many patients we treated. And the only way that the answer will be based on the amount of electrodes that are in the field. That doesn't mean they've used all those electrodes. For the most part, they order 2-3 boxes at a time. So it would be pretty close estimate, but I can get you that number.
It's also rapidly changing. It's probably accelerating.
It's in the last 6 months significantly. We hired an entire team that went after the Urogyn groups because we wanted to win them over and have their approval. So that was a huge plus for us. We've got some big names, more Mikolos and some other people on our KOL list. And so now, huh?
I spoke to more actually.
You talked to more? Okay, yeah. He's a big fan.
a big fan.
He's a big fan. Yeah. Which right there speaks volumes for us.
Romo from
Atlanta. He's from Atlanta.
Is it used in Europe also?
Is it? Yes.